Representative Liebling, would you like to move House File 2527?
Thank you, Madam Chair. I'd like to move House File 2527 to be re-referred to the Civil Law Committee. And Madam Chair, I have a delete all amendment that I'd like to move as well to get the bill in the shape in which I'd like to have it discussed.
Okay. Representative Liebling moves the DE1 author amendment to get the bill in the shape she would like it. All those in favor?
Aye.
Okay. Please, all opposed? The amendment is adopted.
Okay.
Thank you.
Thank you, Madam Chair. And so, members, I hope we can do this pretty quickly. You know, we just spent all this time talking about medical marijuana, and I know you heard me make that comment about dangerous drugs that we use that are legal. And I think many of you are probably aware that we have this thing in the state called the Prescription Monitoring Program, which is an attempt to start to deal with some of the tremendous addiction problems that we're having with opioids in the state. And we've heard a lot about this. We heard a bill recently about naloxone and the attempt to deal with the epidemic of heroin death. And there was commentary about how there's people become addicted to prescription drugs, and then they go on in many cases, in some cases, to use heroin. So our prescription monitoring program's been in place for a few years. Maybe Dr. Weiberg from the Board of Pharmacy is here, and this is really this is housed at the Board of Pharmacy, and the board has a bill which is before us to make some changes to the program. Now, the delete all amendment that we've just adopted is kind of my reconstruction of what the board wants to do. So Dr. Weiberg is here with his bill, but the bill before you is really no longer his bill. It's my many changes to it, and I have really, with the amendment, I've really narrowed the scope of what Dr. Weiberg and the Board of Pharmacy would like to do with the program. And so we can kind of walk through that. And
Okay. Representative Liebling, would you like to move your technical amendment?
oh, I'm sorry. Yes, there is a technical amendment as well, and that is the A1 amendment. So yes, I would like to move the A1 amendment.
Okay. Representative Liebling moves the A1 amendment. All in favor?
Aye.
All opposed?
Okay.
Amendment adopted.
All right. Thank you, Madam Chair. And that was Mr. Chun drafted this for me, and that he told me we needed the technical, and I believed him, and we just adopted it. So, if we could kind of walk through this. Maybe what we should do, though, is give Dr. Weiberg just a chance to kind of give a brief overview of the program and where he's coming from, and then I'll kind of walk through what I've done and where I'd like to go with this.
Okay, thank you. Dr. Weiberg?
Madam Chair, members of the committee, I'm Dr. Cody Weiberg. I'm the Executive Director of the Minnesota Board of Pharmacy. And as Representative Liebling has stated, this bill did originate with the Board of Pharmacy. We have actually been working on legislation for a couple years now. But just for members who might not be familiar, I will give just a little brief summary of what the program's all about. The initial legislation for the PMP was passed back in 2007. It initially required us not to expend any state monies. It took us a little while to get a federal grant, so we actually didn't start collecting data until 2010. And the data that we collect comes mostly from pharmacies, both pharmacies located within the state and any pharmacy outside of the state that ships drugs into Minnesota. They have to report to the board on a daily basis, typically electronically, information on what are known as controlled substance prescriptions for certain schedules of controlled substances. Controlled substances in this context are in schedules, currently schedules 2, 3, and 4. These are drugs that have FDA-accepted medical uses, but they are also considered to have abuse potential. And they are frequently abused, and there is actually an epidemic of prescription drug abuse in the country and the state. We collect that data on a daily basis. Actually, we have a vendor that collects it for us on a daily basis. They make sure that the data was all submitted correctly. Within a day, it becomes available to authorized users of the system. Right now, the individuals that can get a user ID and password to go into the system to access the data are prescribers and pharmacists and certain individuals that work at the Department of Human Services in the Medicaid program that are looking for patients who might be doctor shopping. Doctor shopping or detecting doctor shopping is actually the purpose of the PMP. With the prescription monitoring program, a emergency room physician, for example, who has somebody come in who has perhaps a very suspicious story that doesn't match the clinical signs and symptoms and is worried about whether this person is trying to abuse narcotics, can log into the system, and we have data back for 1 year, which is as long as we're allowed to keep it, and that prescriber then can see if perhaps this person has gone to multiple different prescribers and multiple different pharmacies to get controlled substances filled. So in a nutshell, that is what the program does. Law enforcement can get the data, but only when they serve a search warrant on the board. And we actually have had quite a number of search warrants served on us, but they do not have direct access. Our board staff has access just to the extent that we have to maintain the program. We are also actually the only health licensing board that can use the data in the system to look at complaints against our own licensees. Other than that, those are the sort of individuals essentially that have access. We have roughly a third of the potential physicians, prescribers and pharmacists that could access the system that actually do access it. That's not untypical for most of these programs in other states. 49 states, every state except Missouri, has a program like this or is developing one, including all the states that surround us. So I guess that's kind of just a brief summary of the program, and I certainly can go through the provisions. We understand that the lead-all amendment, and we understand it's a basis for discussions, but I certainly can explain even what that does. So whatever you'd like.
Okay.
Thank you, Dr. Weiber. Do we have any questions? Representative Johnson.
Thank you, Madam Chair. And I was struck by your comment that a third, do I understand it right, that a third of the pharmacies participate?
I'm sorry, Dr. Weiber.
Madam Chair, Representative, you have to think about this in two different ways. Almost all pharmacies have to report the prescriptions that they dispense daily. Almost all of them have to report. There are certain exceptions right now, and we're actually, one of the provisions here would eliminate those exceptions. But what I'm talking about is the people who sign up to actually look at the data that's in the system. Right now, prescribers can only look at the data if they're considering prescribing. Pharmacists can only look at it if they're considering dispensing. And about a third of the prescribers and pharmacists who could sign up to do it have.
Representative Johnson, can you follow up? Okay, thank you. Representative Liebling.
Right. So members, so if you understand kind of what we're talking about here, every time if you go and you get a pain prescription for an opioid and you go to get that prescription filled, your pharmacist is entering data into a database on you and that prescription. So this is pretty, in a sense, it's pretty invasive, and these are the kind of things that, we on the Health Committee know that there's a balance to be struck between data, collecting data, and how we use it, and, this is obviously for a good and important purpose, but I think we need to be kind of careful about how we allow that data to be used, who has access to it, how long we keep it, and for what purposes we allow it to be used. Now, this is going to civil law, so it'll be looked at quite carefully, in terms of the data issues here. I think the issue for us in the Health Committee really kind of comes down to whether this is even effective or could be effective for the purposes for which it has been designed. And that's why in the amendment, one of the things that in the original bill, the board had a provision to study whether we should require prescribers to use this. In other words, the data is there, but at the point where somebody is going to write a new prescription, right now they don't have to look into the data to see if this patient has gotten many other prescriptions filled, but they can, right? So the board is interested in perhaps moving toward a mandatory system where prescribers would have to use it. I'm not against them trying to find out if that would be helpful, but I also have put some things here about having them study whether this is actually useful in helping to deal with the addiction problem, because it seems to me that from the point of view of our interest here in the Health Committee, the whole point of this ultimately is to try to deal with the addiction problem, and if it's not doing that, then I'm not going to continue to support the collection of this data. So,
All right, thank you, Representative Liebling. Are there any other testifiers?
I had a question.
Any
over here.
questions? Okay. Representative Lawford.
Thank you, Madam Chair. I'm just kind of stuck over here in the corner. My question, Representative Liebling or to Mr. Weiberg, is I'm just trying to still get my head, and maybe it's because it's so late after so much sitting and listening, but I'm still trying to understand the real outcome and goal that we're trying to get. Because if the goal is to keep addicts from doctor shopping, but if the result is not to get them effectively into treatment, they just show up their local pharmacy and the pharmacist checks it and says, oh no, I'm not comfortable giving this to you. In our earlier hearing where the first responders wanted to be able to give naloxone, we were told that people who are addicted to opiates are going to heroin because of cost, and that they don't know what they're doing, and that is leading to these cases of overdose, which sometimes can be caught early enough and sometimes results in death. And so my question, so I have a concern about whether or not we're creating identification of a person with a problem without necessarily an effective response to get that person, and so we may end up with first responders responding to many more overdoses on what is apparently easily available on the open market if you know what you're looking for and where to shop with heroin. On the other side, the Board of Pharmacy has a responsibility for making sure that we don't have people writing prescriptions that they haven't given due thought and consideration to whether or not they're appropriate and those sorts of things. And so you could identify practitioners who the word on the street might be, this person will give you a prescription for anything. So I'm trying to understand really what the focus is, and it's maybe both of those, but I also am really concerned about unanticipated consequences to that person who's turned away.
Representative Liebling.
Thank you, Madam Chair. And Representative Loeffler, that's the same kind of concern that I have as well. And I'm sure Dr. Weiber can speak to, if there's any sort of intervention component here. But I think that the purpose of this is not, well, I would say there's a little, perhaps, mission creep going on, because I think the initial purpose of the program is to allow prescribers to have a tool that will help them prescribe or not prescribe, as the case may be. But then the idea of using this as a tool to look to see if prescribers are doing something wrong is kind of an additional purpose that I'm not sure we really are ready for that. I don't think the Board of Pharmacy is the proper place for that. The pharmacists aren't really tasked with overseeing other classes of licensed professionals who have prescribing privileges. It's kind of not their function. That's at least... Okay, well, he's going to contradict me, but so I'll let that's fine. He knows more than I do about it. It's fine if he does.
I'm not going to,
Okay.
Madam Chair, if I may, it's not contradiction, it's just a clarification on a couple of points. First of all, the Board of Pharmacy actually does not support mandatory use of the program. Very clearly, we do not support mandatory use. We do not support requiring prescribers or pharmacists to utilize the system every time they're going to prescribe or dispense. We think that would create a huge burden on healthcare providers with very little benefit, because I'm convinced that a very large percentage of controlled substance prescriptions are for completely legitimate purposes. In reality, when Barb Carter, our PMP manager, and I came to talk to legislators last year, most of the legislators we talked to said two things. We really like the PMP. We want to require its use. And that, when we had all these legislators saying that, it's like, this apparently is something that wants that people may want at the legislature. We don't think that's really a good idea. So let's take a look at some alternatives. And one of those alternatives is actually not in the delete all amendment, so I won't talk about that. But I wanted to make it very clear that we do not support required use of the program. The other thing that I would like to say is we also, even more, the board itself even more strongly opposes using the prescription monitoring program to monitor the prescribing patterns of prescribers. We're adamantly opposed to that. We are convinced that that would have a chilling effect on legitimate prescribing. We would not ask for legislation like that at all. So I just wanted to clarify those two things.
Representative Loeffler?
Well, thank you, Madam Chair. And that's helpful, but I'm still wrestling in my mind. Where does this appropriately fit? What is the focus, and are all the people affected, have they been involved in putting this together? Because I really do feel like it is a major program. And having just heard testimony from people who somehow managed to continue to function with outrageously high levels of pain pills and who are looking for alternative medicines, I don't know if how do you know which ones to check into and which ones not to in terms of filling a prescription or deciding if it's appropriate? And I'm not skilled at all to ever judge that. But I'm just wondering if the people who see the information here would have that background or not.
Dr. Weiber?
Madam Chair, Representative, so right now the primary individuals that use the system are prescribers, so physicians, nurse practitioners, physician assistants, podiatrists, dentists, and pharmacists. They're the ones that are taking a look at the data and trying to come to some sort of a judgment as to what's going on with this person based on this data. We do emphasize that this is just data, and they can't just look at the data and jump to conclusions. They should be engaging their patients in discussions. The other thing that we've done is we do have portions of our website that have information on it for prescribers and pharmacists on appropriate pain management. The boards of medicine, nursing, and pharmacy have actually, for many years, put out a joint statement on pain management, how there needs to be a balance between making sure people with legitimate pain get the treatment while also trying to prevent abuse. And so, and there's other resources. So we have resources about how to appropriately manage pain. We have resources about how to appropriately refer people to pain specialists or to addictionologists. And our message when we go out and talk to professional groups about this around the state is very, very much, we hope, we can't force people to do something when they're using this data, but we tell them what we hope they do with this is not simply to kick someone out of their ER or their pharmacy, that they try to intervene if they think that this person really has a problem and get them the help that they need. The other thing I would say is the Board of Pharmacy is one of 8 or 9 different agencies that's part of the state substance abuse strategy. And what we're looking at here is a multifaceted approach to this problem. And so the Board of Pharmacy's role is to provide this one tool, which I have always acknowledged is just one tool in terms of the supply side of the issue. The board has also worked to get legislation passed several years ago to deal with the illicit purchase of these drugs on the Internet. We've worked with the Pollution Control Agency and local law enforcement on drug take-back programs to get drugs out of people's medicine cabinets. And but we're also working with like DHS. They're the experts on treatment and prevention and trying to get people to not abuse the drugs and to get them into treatment. So it's a multifaceted approach. This is just one tool in a much larger toolkit, if you will, that multiple state agencies are using to try to address the crisis with prescription drug abuse.
Representative Loeffler.
Thank you, Madam Chair. Just one last question. Can you tell me what outside, other than your board, what other organizations have reviewed this and taken positions on it, if you're aware of any? Mm-hmm. That would be helpful.
Madam Chair, Representative Loeffler, we have one of the things that the Delete-All Amendment does is formally reconvenes or reconfigures our advisory committee. We were unaware of a portion of law that automatically sunsets advisory committees. But when I drafted the original legislation for Senator Berglund, I included the concept of an advisory committee in the bill. And the advisory committee includes representatives of all of the professional associations involved, all of the health licensing boards, the Department of Health, the Department of Human Services, Rich Neumeister's on there for data privacy issues, and we have a public member. In addition to that, we've done actually extensive work with the Minnesota Medical Association to address concerns they've had over the last couple of years. We've been working on this particular piece of legislation for 3 years, and we're not like a cabinet-level agency. So in our case, all legislation, before I'm allowed to come work on it, has to go before a board, our board, at a public meeting. And so we've held our own meetings where the board has taken testimony on this bill before the board. I have to say that in the 15 years I've worked at DHS with the board, this is the most well-vetted bill I've ever worked on, actually. So.
Thank you, Madam Chair. That was helpful.
Thank you. Do we have any? Sorry. Representative Gruhagen.
Well, thank you, Madam Chair. No, I just want to mention to Representative Liebling, I appreciate your caution on this. It's so easy to let information out, and it's another thing. So I think you're slow as you go, and be careful. It's always easy to prevent something that is done to something once it's out there. So I just wanted to compliment you on that.
Yeah.
Representative Liebling.
Thank you. Thank you, Representative Gruenhagen. Sorry about that. I think we bipartisanly are very cautious about, all of us to different degrees, I suppose, but I think we in the House are all very concerned about the use of information, whether it's, in all kinds of different contexts. And maybe it's just a culture we have, but I think we share that bipartisanly, that we want to make sure that when data is used, that it's used for the proper purpose and only as far as the need is, and that. And as I said before, there is always a balance to be struck. We certainly can't have the medical miracles that we do have without the use of data, and we can't develop new drugs without the use of data, and we can't. So we have to use data in certain times, in certain ways. But I think it's incumbent on all of us to make sure that those ways are proper and completely vetted.
Yeah, thank you. Is there anyone else who would like to testify? Can you please come to the... Thank you. Can you please give us your name?
I'm Dave Hartford. I'm a DHS Assistant Commissioner of Chemical and Mental Health Services. Thank you for the opportunity. And I just wanted to make a few comments around this bill. Certainly since 2013, when the state substance abuse strategy came forward, one of the policy priorities was to strengthen our prescription monitoring program. It is one of the tools nationally as a tool to change and have an impact on the opioid problem. This is a huge problem nationally. And if you just look at what our prescribers are faced with, over the last 20 years, we've done a much better job of assessing, asking patients their levels of pain. We assess pain in a much different way than we did years ago. The downside to that is we're also prescribing much more opioids along with that. In fact, you can get lists of facts around this, but the fact that the United States has 5% of the world's population and is consuming 80% of the opioid medication, it just goes to show. I mean, we have had, I think, one of the biggest pieces in our community, Hennepin County, in, 2008, we had 6 deaths in Hennepin County associated with, this is heroin. And last year, we had 56 deaths, from 6 to 56 deaths. And in polling of heroin addicts, it's up to 3 out of 4 starting with prescription medications. I've heard many stories recently, not the use histories that sometimes we think about when you think about people developing lifetime addiction habits. I've heard use histories of 6 months, 8 months. Somebody had a catastrophic surgery or a healthcare condition and they had started on opioids, and because their prescriptions ran out or for whatever reason, short use histories, and going to heroin to deal with that addiction. And to kind of get to some of the questions that were being talked about in here, prescription monitoring is just one tool. Our prescribers are caught between balancing the pain and what are the risks of addiction, of poor outcomes for their patients, and they need information. One of the successes, I think, through last year is we had more than 3,100 new accounts with this prescription monitoring program. As Mr. Weiberg was saying, we still only have about 1/3 of the prescribers using it. But we're in the middle of really trying to push forward education across our physicians' prescribing practices and how they think about opiates, and that's a very important. So all of the campaign, I think, is really working in that many more prescribers are utilizing that, thinking about addiction. We're doing a great deal of training, and to get to some of the point, that's an opportunity. If somebody goes into a physician's office and they try to get a prescription to carry on, and the physician gets online and sees, this person is received a great many prescriptions, and I don't think this is a good idea, that's a chance for that physician prescriber to intervene and try to get the person the appropriate help possible. And that's where engaging in our healthcare system to really take on as a whole this opiate problem. And as, again, Mr. Weiberg was saying, it's a multifaceted approach. We're in DHS looking at a myriad of other treatment ways to deal with opiate addiction from a treatment standpoint, not just our methadone clinics, but other ways to have treatment within primary care clinics. And he went through a long list of what are all the things, because it's not just one thing that's going to change this trend in opiates. And again, this is just one tool in that toolbox that we have to give the prescribers that information. Because if they're unaware of what's going on with the individual, how are they going to make informed choices?
Thank you. If there's any question for Mr. Hartford? Members, is there any questions on the bill? Okay, so why don't we move to a vote? And so Representative Liebling renews her motion that House File 2527 as amended be re-referred to the Committee on Civil Law. All in favor?
Aye.
Any opposed? Okay, the bill is referred to Civil Law. Thank you. We are adjourned.